Black men in the US live 4.5 fewer years on average than white men, and much of this gap in life expectancy is driven by chronic diseases such as hypertension and diabetes. The fact that these conditions can be managed with preventive measures suggests that differences in healthcare utilization may play an important role. And in fact, research shows that relative to white men, Black men are 6 percentage points less likely to visit the doctor. To what extent does lack of physician diversity contribute to this problem? While Blacks are 13% of the US population, they are only 4% of physicians and less than 7% of recent medical school graduates. Would Black men be more inclined to go to the doctor or to trust the medical advice they are given if their doctor were Black? To investigate this question, the authors conducted a randomized controlled trial in Oakland, California. Between 2017 and 2018, over 1,300 Black men were recruited from local barbershops and flea markets. After completing a baseline survey, each subject was given a coupon to receive a free screening for blood pressure, BMI, cholesterol, and diabetes at a nearby health clinic. Nearly 650 men decided to redeem their coupon and were included in the following two-stage experiment. First, upon arriving at the clinic, each participant was led to a private room and given a tablet. This introduced them to their assigned doctor, including the doctor's name, and importantly, a headshot. Approximately half of the sample was randomly assigned to a non-Black doctor, while the other half was assigned to a Black doctor. Using the tablet, and before meeting their doctor in person, patients selected which of the 4 services they wanted to receive. Note that screening for cholesterol and diabetes is more invasive, as both require a finger prick of blood, a detail that was clearly communicated on the tablet. After selecting their services, patients were asked whether they additionally wanted to receive a flu shot. A random subset was assigned to receive an offer of either $5 or $10 for selecting the shot, while the remainder received no financial incentive. In the post-consultation stage, patients met their assigned doctor, who was instructed to encourage all patients to receive the offered services. After this in-person consultation, patients could revise their choice of preventives, which the doctor then administered. So, the key question is, did being assigned to a Black versus non-Black doctor affect patients' decisions? The authors study the effect on the pre-consultation selections made after patients were introduced to their doctor via the tablet, as well as the post-consultation selections made after meeting their doctor in person. And they find that doctor race had no impact on patients' pre-consultation decisions. On its own, being assigned to a non-Black versus Black doctor had no meaningful effect on demand for treatment. The picture looks very different, however, in the post-consultation stage. At that point, patients randomly assigned to a Black doctor were more likely to select each of the offered services, and by margins that are medically meaningful. After meeting and discussing with their doctor in person, subjects assigned to Black doctors were 18 percentage points more likely to take up preventives than those assigned to non-Black doctors. Note that patients with non-Black doctors also increased their demand for screening after the in-person consultation. However, the difference in pre- versus post-consultation demand was significantly larger for those with Black doctors. This figure plots that difference in post-consultation take-up between patients with Black doctors and those with non-Black doctors. Not only is this quantity positive across each service, indicating that patients with Black doctors elected for more treatment, the percent difference between Black and non-Black doctors is positively correlated with the invasiveness of the test. In other words, having a Black doctor appears to be especially important for tests that are more invasive. So, why is this? While there are several potential mechanisms, the authors provide evidence suggesting the results cannot be attributed to differences in physician quality, or effort, or even discrimination. Instead, the key seems to be better communication between Black patients and Black doctors. This is consistent with evidence collected from doctors' notes and patient feedback at the end of the clinical visit, and would explain why the results are stronger for more invasive exams, which are riskier and thus require more trust in the person providing the service. Using a back-of-the-envelope calculation, the authors estimate that Black doctors could potentially reduce the Black-white male gap in cardiovascular mortality by 19%, and the overall life expectancy gap by approximately 8%. While they note that such extrapolation should be interpreted with caution, this paper provides evidence that physician diversity can have a causal impact on health outcomes. As always, you can check out the full paper and its references to other related work. These include studies on racial disparities in health outcomes, papers in both public health and economics exploring one potential explanation for these disparities, namely distrust of the medical establishment and historical contributors to that, and finally, many papers studying the role of diversity more broadly in moderating everything from cooperation to labor market and educational outcomes.